maybe you've got attitude, I don't know. None of these things have attitude. If you're really rude to the patient, or you're really rude to staff members or something, or you know, that we don't want reflected in ourselves or, you know, in you guys as a program, we might do a conference then. It's not like you're going to find this conference then a week later in the mail. We will talk to you that day. We'll just say, hey, can you talk to me for a quick second? And go over that conference then, because you can sign it. And then usually even with the conference then, we're going to say, okay, what can we do today? Okay? You showed up late. I know this is the second time that you showed up late. How can we fix this? Or you came in like the most critically scrubbed I've ever seen in my life. I mean, that would be expected, like really, because I've been really but you know what I'm saying? Like you come and you've got 5 piercings, but you know, it's endless. It's at our discretion. So just saying in that, but we would draw a conference form and go over that with you. So if there was something a little bit more severe, like a med error, or something, you know, major that happened, and you guys just decided to move clinical or for whatever, who knows, that would be an unsafe occurrence. If you look, it is under the handbook, what specifically would occur for an unsafe occurrence. And med error is one of them. So you guys know that. Yeah, what's up? Yes.
Yeah. At what point does it qualify for medication? Is it when you actually join meds? At what point you actually the medication?
So what I do, because I don't like when the students are, when you guys go into the room, I don't like to point it out then, right? Because you guys are with the patients, right? And I don't want the patients to think, oh my gosh, they were about to give me the wrong medication, right? So what I do, and maybe we should all do the same thing. I'll just see what you do at all. But we do our 3 checks, right? You guys do your 3 checks. At this level, I'm not going to sit with you and do all of your checks with you. I'm going to say, okay, did you do your first? Have you done those? Did you verify it with the EMAR? Did you get everything? You've done your checks, and then you come and do the 3rd check with me. Okay. Once you're done your 3rd check, and I say, okay, you have everything that you need, I'll usually say, that's usually a hint that maybe you don't. But okay, do you have everything that you need? Is there anything else that you'd want to change or anything else that you're missing? Then you'd probably do a quick check just to make sure. And then you say, okay, no, I'm ready to go. And then we would leave and I'd say, okay, let's stop for a second. And then I'd go over that. Okay, so it's giving you guys every opportunity to do all 3 checks by yourself, but not actually be in the patient's room to make that error, right? Because in all reality, like you probably, if it would to happen, you would have gone into the room and probably given the medication, right? What are your thoughts? Okay. Oh, well, good, good. Mm-hmm. Yeah. Because I've had students say, well, I would have caught it when I was scanning it. And my thoughts initially were, well, yeah, in real life, you probably would have, but should that be, computers should not be catching our mistakes, right? So our thoughts are, no, you need to do your own 3 checks out here. You need to be confident that everything is ready, because have we always had computers? And will you always have computers? No. So we need to make sure that you're 100% safe before going into the room. And computers are just a bonus. Okay, they catch things all the time. But Jesse, what do you think? What do you do on clinical for med errors? Similar? At the med cart. Yep. Yeah. Yeah. We're going to give you every opportunity to get it right. Okay. We're not going to, at the med cart and you miss something and it's still your 2nd check, I'm not going to point it out because I want you to find it out. Right. So I'm going to wait until after all 3 checks. Okay. So we're going to give you every opportunity to succeed. So deep breaths. She's not the med Nazi. She's fine. Okay. Sometimes. Okay. Should we get into paperwork? Do you guys need, oh, it's only been an hour. We're good. These are comfy chairs. I feel like I could sit here all day. Where's my, all right. people who had emailed me with different issues. I made a few changes, and also the red that was on there, that was just a red block before, is now filled in. It'll be yeah, you're the one that asked me that. I looked at it last night. Yeah, they do, except for ER. ER, it shows that tax is grading that paper. So it's in purple, but on the back, it's under mine. It doesn't matter, it all goes the same way, but I would be grading the ER paper. But besides that, all the colors match where you're going. Both myself and Stacey are going to PCU, but our colors are different. So Stacey, if it's an orange PCU, you'll do it. If it's a pink PCU, you'll do it. So that the back. The only one that actually colors is the ER. That's a special. Right, and you know, all you do is you're just submitting paperwork, so it all works in the same place. And then you just start to apply it. So you're not submitting it specifically to that instructor. You're submitting it to the drop off. We'll just go in here so that you guys can see it. I think I know what you mean, like clinical number 1, clinical number 2. Is that what you're saying, Natalie? So if you're going to drop your paperwork, you go into clinical paperwork and lab submission. And depending on what you're doing, it's going to be probably majority of these first 2 here. If you're doing a specialty, you'll click there. Acute care clinicals. Yeah, and she's got them labeled 1, 2, 3. So yeah, it wouldn't be a bad idea to keep track of that. So you're not, I mean, it won't let you, if I've already put 1 into clinical number 1 paperwork, it's not going to let you put it, because you already have a grade for number 1. It shouldn't let you? How? Would it override? Oh. And you can look in the grade book too. I mean, you could look at the grade book before you submit, just to make sure you're putting it on the right one. Mm. Yep. Oh. No, it doesn't matter. It just matters where it goes in the grade book. Like for us grading it, it doesn't matter. It doesn't make a difference. At the very end, one thing to point out, make sure that everyone's listening. If you are on site clinical, the paperwork is different, and we are going to be going over that. Make sure that you do not submit it into acute care number 6 or number 7, because the rubrics are different. Okay, points are the same, but rubrics are different. So any clinicals that are psych, he does a different database, because psych is just different all around, right? Just has to be different. Make sure that it goes into here, because it's the rubric that Roger gets to grade from is going to be different than our clinical ones. Okay. Yes. Nope. Specialties. Let's go over that. I don't have enough. Yes, I do. Let's look at the clinical schedule here before we get into our paperwork a little bit more. So you know that it's a specialty if you're not with a faculty member. anything that's not with one of us is a specialty. Okay, so I can go through if you guys want to jot down. Some people like to put, SP next to it. Just literally flip it around and right next to it, so you know what's a specialty. Okay, Women's Surgical Center, specialty. NICU, specialty. Labor birth, specialty. Now we're in the pink. Post-surgical care unit, that's a specialty. ER, specialty. Stanford Periop is specialty. OR is specialty. Now we're over on the other side, purple. Same-day surgeries is specialty. Home health is specialty. Heart view specialty. ICU specialty. Interprofessional collaboration is specialty. Cath lab specialty. Infusion is specialty. Ped specialty. Team lead specialty. KDU specialty. Dakota Alpha specialty. And that's it. The rest of them you will be with a faculty member on clinical. Yeah, no, but basically, on Tabby's side, because there's just a lot in a row, she's grading a lot, the majority of the specialty paperwork. Same day surgery, all the way down in purple. All the way down to Dakota Alpha, all of that specialty. Okay. Okay, so Melanie will be with you. We should have said that maybe when we did a little bit. Melanie will be with you on GYN and Mom Baby. Okay, so if you're going on one of those clinicals, those are inpatient clinicals, you'll be with Melanie. Clinicals for myself, well, you'll be with me, our PCU, and the clinical simulation day, which we'll go into more detail. So PCU and sim, you're with me. Carmen, who you'll meet later, she's going to 3 Center with you, that's ortho. Abby, who you met earlier, she's going to Vibra, you'll be with her. Stacy, I just saw Stacy. There she is, Stacy. She's going to PCU with you guys. Tabby is doing a pediatric sim day at the school, and we'll go over that. So she'll be with you for that day. But otherwise, all the rest of the purple are specialties. She's grading those. Jessie in the back is going to TCU with you guys, plus she's doing 1 clinical simulation day at the school. And then Roger's with you at psych. Okay. Continue to email me if you have questions about it. As you can see, this is a beast. Like my brain, I've had many migraines trying to fix this and do it. But please email me if you have questions. I've had people email me, Peggy works in KDU, and I didn't know that, right? And I had her in a KDU specialty. So, yeah. ICU or the IC? IC, yep. Yes, that's a good point. So if you have IC and it's green, you're with Jessie on TCU. Yep. So your IC, your intercollaborative one, is going to correlate with your color. Okay. So if it's orange, you're going to be with Stacy that day on PCU. And all of them should have a color with them. If it's pink, it's with me on PCU. Okay. It's different paperwork. Yep. And we'll go over that. Yeah, but you're kind of with that group a little bit because you'll do post-conference with that group. Okay. A few other things on the schedule. You've got on September 25th, we've got our QSIN projects. You went over that yesterday. No, you're doing that today. We're going to go over that today, the QSIN project that you guys are going to do together. And then after that day, after September 25th, we start doing simulation. We start having our simulation days. We start doing some simulations later on in lab. So that day too, we're going to do a simulation orientation. I'm going to take half of you in the morning. She's going to take half of you in the morning. And then we're going to swap for the afternoon so that everybody gets simulation orientation. How to use the mannequin, what we do. Yep. What do you mean? Right. Not everyone got into the sim day. Yep. Yeah, but everyone should have the pediatric sim because she's doing one this semester and then she's going to do a different one next semester. So everybody should have the pediatric sim this semester. Who's talking? Oh, like nobody's looking at me. You have the P-Sim. It's the purple P-Sim right there. Okay. So yeah, everyone should have pediatric sim. Not everyone will get an actual sim day, but you'll all get simulation of some sort. The other date on there is the health fair. I'll talk a little bit more about that later. What we do is we have you guys into groups, and you guys, we actually do a health fair up here on campus over in the student union. We correlate it on a day, I think it's on like the potato bar day, which they're going to switch it. So I'm like, that's not really health conscious, potato bar.
Oh, come on.
That's true. I mean, cheese sauce and bacon and just like, so anyways, they're looking at switching what the students are actually getting that day because they give out free food and stuff. But we're going to be set up over at the student union. You guys are going to get together in groups and talk about, make poster boards about a topic, about a health topic. And I'll get more into that in a little bit later. But that's what we're doing that day. I put 9 to 2. 9, you can show up at 9 because it's probably not going to start until about 10. So we have like an hour to kind of set up everything because some boards are pretty elaborate. So we got Thanksgiving, and then the last on the schedule is the OB simulation, which is all you. Okay. Any other questions about this? If it's about yours, shoot me an email. Okay. What's your question? Her first one, she's doing the pediatric sim with you guys. Yep, but after that, she grades all of the specialties. Okay. All right. So just so you know who's grading it, like that's what it's colored on there. Okay. Yes. Yeah. Oh, yeah. Like these are the documents that you guys could write on. Even just say boxes next to it, and you could put number 1, number 2. Yeah. That would work. Good idea. Yeah. Oh yes, we have yet to even delve into the paper. Yes, there is. I have a whole list. Okay. Mentor sign up. Maybe you guys have heard about that. You guys remember that at the PO level, right? If you are wanting, if you found this really helpful, or you didn't find it helpful, and you want to be a better mentor than what you had, yes, some of you have good ones, and then some of you were kind of non-existent. But you know, it is what it is. Be better than what you had, right?
You guys listening? Hello?
Talk louder. Sign up if you want to be. You've got to start for your name and then your email. Okay, then Deb is going to put you guys with a PN student. It should be 1-to-1 because we have about the same amount of students, depending on how many people sign up. But sign up if you would like to be a mentor to somebody in the PN class. We would appreciate it. All right. Clinical schedule. Any other questions before we get into the guide, clinical guide here? And let's see, are you recording already?
Yes.
Oh, all right. Awkward. Okay.
I did go in and I changed all the submission areas to a single attempt. So make sure that when you make that attempt that you get it right. You know, you can upload more than one document, but make sure it's the one, the correct one, because that'll be your one-time chance at it. So, and I will, if I haven't yet, but I'll go into special and do the same thing. I think that'll help, you know, so things get lost at the end of the semester and buried under submissions.
That shouldn't make a difference, right? For
Yeah.
changing it. Yeah.
You won't be able to resubmit. I mean, you'll get your second time report, and that's what it is.
Mm.
So it's just, it's to see, you know, what and paraphrasing and things like that. It's a tool for us so that we can make sure you're not recycling your papers or someone else's papers. Because no. Right. Yeah.
thing, paperwork. Everyone look at your schedule, your clinical schedule. The only ones at Stanford, we have certain forms that we have to fill out if you're going to Stanford. They're just going to be for specialties, so what they need you to do is fill out the name of the person that you're following, the employee, the area you're working in, the date, and then the total amount of hours. That's for their, I don't know, they get into big trouble with JACO if this isn't filled out. So the only clinicals that are at Stanford are periop, so SPO, and same-day surgery, I believe. Just those two. So you have to fill out, if you're going to both, then take 2 of these forms, okay? As soon as these are done, bring them back to me, and I have to send them off to her right away, okay? So if you're going to Stanford, if you're going to see SPO or SDS, same-day surgery, you're not going to Stanford, then ask on the forms. Okay. Okay, I think we'll go over the clinical guide and then we'll take a break after that. Perfect. It'll save us a lot of heartache and backtracking later. All right, let's go over the clinical guide. This is what you're going to be filling out. This is for each. This is, if you were looking where it is in Blackboard. Oh, come on. It's under paperwork. Most of the stuff that we're going to go over today is going to be under paperwork. Okay, if you're submitting it, you're going to submit it into this section, submission. If you're looking for the paperwork, you're going to a clinical and you got to print off what you're going to do or whatever, you go into paperwork. Almost everything is in here that you're going to need. Okay. All the templates, all the guidelines, when you're looking at your guidelines for where you're going to go, all of that is under paperwork. Okay. Yes. It will be. I thought I put it in here. Where's the template? I've got my specialty ones. Oh, I've got the specialty templates. I wonder if I didn't put the clinical guide template in here yet. I will get it in there and I'll put it right under the paperwork, just like where I have the specialty templates, okay? So this is the paperwork that you're clicking on. Okay, clinical paperwork. It says medical, surgical, ICU, CCU, because when you go to ICU, you're going to be filling this out as well. But that is where your clinical guide, this is your clinical guide. Okay, so you're going to notice a lot of similarities because some of the questions are similar to what you did on the data collection. You've done the data collection for the last 11 months, and now you're going to do a clinical guide. Okay, so first things first, literally put your name, date, make sure you put the right name. Tabby kind of put this together last year, and then we all went through and kind of added our little things. So this is a compilation of all of us in one and what the expectations are for all of us, okay? So gone are the days of, well, I want this and you want this. This is hopefully going to take that away so we're all consistent, okay? Because you guys want consistency, we want consistency. So you don't have to go to each clinical and say, oh, you're with Melanie this time, she wants this. No, we all want this, okay? Hoping, right? Yeah, hoping. Okay. Remember that this is a formal college level paper. Please ensure that your grammar, spelling, I mean, it should be typed out. We don't want everything handwritten. APA, and at the very end where you get the points for your APA, I'll show you what places there are. Because a lot of this is kind of not sourced, right? It's more like your thoughts and your patient. So I'll show you exactly the parts that need to be APA. So number one, write at least one cognitive goal. They had to do goals at the PM level, didn't they? When you went to clinical? Oh, you had no goals. You just showed up at clinical? I didn't know that. Just come and Be free. Okay, so for this one, you need to come with one clinical goal, one psychomotor goal. So these can be things specific to the area that you're at, okay? So obviously goals for PCU with me are gonna be different than goals for Mom Baby with Melanie. Think about where you're gonna be. Think about the patients that you're gonna take care of there. What have you not seen? Like maybe you haven't seen a chest tube yet, and maybe your cognitive goal is to learn more about how the chest tube works. Or your psychomotor goal is to actually measure chest tube output. And make sure that it's just specific to where you're at. Okay, that's pretty easy.
You guys know the difference between cognitive and motor goals.
Well,
Cognitive is learning, knowing, understanding, you know, thoughts and knowledge. Psychomotor is your motor, your hands-on skills, getting in and doing things, technical hands-on stuff. That's your psychomotor goal. And then your affective goal is your feelings, your how it makes you feel, more the psychosocial piece. So
and at the end of the guide, we'll go over because you're going to be talking more. You kind of do a little affective reflection. So if you're looking and you're kind of confused about, you know, what's cognitive, what's psychosocial, Carrie actually has the definitions in here, and it goes over cognitive, psychosocial, and affective is in here. Psychomotor, what do I say? Psychosocial. So learning goals, and that is actually in under your paperwork. So you can pull that up to get a refresher. Yes. I haven't put that in. That's why I write myself a note. Sorry, I forgot. My brain, there's too many things. I will put that up when we have a break here so you guys can use it too. Okay, so number one, you're writing them out. You're coming with those filled out, ready to go, okay? A lot of us are going to ask what those goals are in pre-conference. So when we meet, I'll say, what's your cognitive goal? Because I like to write it down so that I can be looking, or psychomotor, so I can be looking for those opportunities. Yes. In the what format? Oh, I'm like, I don't know what that is. Oh,
it sounds good.
that sounds great. What is that? No, type them out. Oh, I thought you said smarkle. Didn't you? Smarkle? Smarkle, like not smart, but smarkle. Well, I get it, but I heard her saying smarkle. Like, no. I like it. No, you literally just write it in a sentence so we know, like this, my cognitive goal is to blah, 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 blah. No. No, I know what you mean. Smart goals. I didn't even say smart. Smart goals. Smart goals. I'm here, smart goals. I'm gonna make up my own smarkle. This is what I'm hearing. I need to like clean out my ears. Okay, so that's number one, writing them down. Number two is explaining how you're going to accomplish these goals. That's 3 points, okay? So we want details. We don't just want, I will ask my nurse or I will ask my instructor. If you want to learn, your cognitive goal is to learn more about chest tubes, how you're going to accomplish that goal should not be to just ask your nurse, okay? So where are you gonna research? I found this website and I'm gonna use this information that day. Just be more specific, so more details. You do focus on, you know, the points that you get for that. You get 3 points for that. So make sure you tell us what you're going to do. If it's a psychomotor goal, it might be my patient has a chest tube, so I'm going to make sure that at the appropriate times, 8 and noon or 6 and 10, whenever they do it, I'm going to check that output, and then this is how I'm going to do it. Okay, so just specifics there. Next part, client history and data. That's 1 point, very self-explanatory. Fill in that in. Number 3, reason for admission, admitting complaint, history of their current condition, including dates if they have it, okay? So obviously if they had their appendix out 50 years ago, like you don't have to put the date on there. That's totally fine. But why was that, or sorry, that's in the next one, number 4. But number 3, reason why they're admitted. Why are they here? That's pretty easy to answer there, right? It's worth 1 point. What led up to this admission? Maybe they were coming in for an open heart surgery, and they had a cath 3 weeks ago that showed this and blah, blah, blah. And now they're admitted and they had the surgery done. They were in ICU and now they're on PCU. Something. Okay. Number 4, past medical history. So this is where, I mean, if you have the dates, put them. If you don't have them, obviously that's okay. Put as many dates as possible. But list what's their medical surgery, what's their surgical history there. Pretty self-explanatory. Physiological adaptation, reduction of risk potential. So based on your client's condition, what complications? So what should you be alert for today? This is something that probably a lot of us will ask in our pre-conference too. I always ask, what's your priority for the day? What's the one thing that you're worried about happening to your patient? What are you going to be alert for? Obviously, there's multiple things, but there should be one thing that you're going to be for sure focusing on, right? So we're thinking about those complications. What are you going to be alert for? In this section, you're going to be listing complications that can occur. You're not listing, diagnoses necessarily. You're just listing what nursing complications you're watching out for. And then tell us what signs and symptoms. So exactly like this, you can literally take this template and delete what's not needed and then just insert your data. That's kind of probably the best way to use this template, okay? Obviously take out our explanations of what it is, but feel free to do that. For example, if they came in and they have respiratory distress, that's a complication that I'm looking for. What kind of signs am I looking for that would show respiratory distress? Aspiration, what are the signs and symptoms of aspiration, and so forth, okay? What you're going to do then in number 6, you've got 6 nursing prior. I know it's written. Look at this. You can just delete and insert. I mean, easy. You guys have it easy. If there was people from last classes, they'd be like, man, I wish we had this. 6 nursing priorities for your client today. Okay, what are some specific interventions necessary to prevent those complications? So they're kind of going to go with number 5. The complications that you have are also going to align with what interventions you're going to be doing, okay? 6 top priorities. Like I said, they're going to align with number 5. You need to list at least 2 to 3 nursing interventions. Highly recommend that you use the format because it's very easy to just jot down. Different examples, infection, maybe your priority is, what kind of priority? Respiratory distress. Maybe we're going to do a focused respiratory assessment and our interventions are going to align with that. Or we're worried about airway maintenance or bleeding. What kind of interventions are we going to do to prevent that? Pain. Our priority is pain management. So we are going to, number 1, assess their pain every hour or however often you want to do it. Number 2, give pain medication because they have morphine in their MAR. Number 3, use non-pharmacological pain management. Okay, so list the priority and then list what you're going to do for that priority. This is kind of a tricky spot for some people. Maybe you're worried about skin integrity and that was a potential complication that you had. You already have the signs and symptoms of what skin integrity or lack of skin integrity, I guess, would be above in number 5, and your priority is going to be skin integrity. So what things are you going to do for skin integrity? I'm going to reposition every 2 hours. I'm going to make sure that they have a specialty bed, things like that, okay? Does that make sense? Questions about those 2 categories? Yes. Yes, use complete sentences. 24, what? Oh, way to be the downer. No. It's really going to help. I think this is really going to help you guys. Just kind of organize. Maybe it's just me being more type A, but like to organize your brain this way will probably help you guys a lot more. There's always things going on. Don't come to me and say my patient doesn't have anything. I'll be like, oh really? Okay, let's talk about this. Okay. That happens occasionally because we don't know that they're going home and we assign them the day before or something like that, but more often not. Then you can focus on education. Going home. Yep, don't you worry. Yes. You're the 3rd person to ask that. I'm going to upload it on the break, and I forgot to upload it. So, yeah, sorry. Does any other faculty, Jesse or Stacy, do you have anything to add on those sections? I feel like those are kind of big sections that get confusing sometimes. This part's tabby. Yep. Right. Keyword, priority. Right. Right. And these type of things, like bring your guides with you, because you have to bring your guides anyways, because it has your goals on it, and you can write on it. That's fine. You don't have to bring it typed. But bring your goals with you. And during clinical, I mean, we can go over and just say, I'm having a hard time. I can only think of like 3 priorities for my patient. We can help you, during clinical. So this is not all done just after clinical. It's during clinical too. So now, mind you, I am not going to say, well, put this down. I'll say, what do you think about that? And we can talk through it together. Okay. What you guys thinking? Yeah. That happened, right? Yeah. Yep. Yep.
That's just, I mean, that's just life.
Yep.
Even from the beginning of your shift to the end of your shift, you might have changes in priorities. So.
Yep. A lot of students take this with them when they go to get their information. And because there's a lot of this stuff you can fill out beforehand. I mean, we should be coming to clinical knowing a lot about our patients, that we should be able to have some priorities already in our brains, right? And already written down. So a lot of this work, some people would come and it was typed out already. They had everything filled out. And then, like Melanie says, some things change, right? So then you got to tweak things here or there, and that's fine. But if you want to do a lot of the work ahead of time, you certainly can. But we all should be coming with our goals and what are our priorities for the day, for sure. Okay. Okay, number 7, we're looking at healthcare provider prescriptions. I don't like that. The prescription word. It's orders, basically, right? What are your priority provider orders? Is it to check vital signs every 4 hours? That's probably, I mean, yes, it's priority, but like Jesse said, sometimes we'll see these orders and it's like, but is that like priority? I mean, they're here for aspiration pneumonia. Like, let's make sure that we put, respiratory orders in there, right? Maybe they did an x-ray that day because their stats were plummeting and they were more coarse or something like that. That would be a priority order for your patient, okay? She's got an example in here. After you've listed your top 6 orders, you have to explain why, right? So we're putting our rationales to these orders. So for an example, vancomycin, that was the order 250. My patient was admitted for sepsis, they're MRSA positive, and then blah, 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 blah. My patient was most likely put on this to treat sepsis and MRSA. Okay, so you're putting your priority order and the rationale. What's another example of an order, priority order? Think about what in your area, what would you put for mom babies? No. That's important. Okay, and you explain why. Yep, in full sentences, just say why, talk to us. Number 8, discharge plan. So I've seen a lot of this, NA. My patient didn't go home. It's like, well, when does the discharge plan start? On admission, exactly. So discuss the discharge plan for your patient. If the discharge plan has not been made, what goals do they need to meet? Don't just say, well, they're not going home. They're probably going home tomorrow. Well, why are they not going home today? What do they have to do before they can go home? And just explain that. That's worth 2 points there. So what's the status of the client's discharge plan and what goals must be met before discharge, okay? There's a lot of those questions in here, the and this. When we get to the education, it says, well, what's the education you gave and how was it received? That type of thing. Okay, so be careful of those, even circle them if you need to. Psychosocial. The section is your patient's social determinants of health. So explain what their social situation is, and then discuss how this affects their health. Everyone comes from different backgrounds. I mean, you don't have to, do a whole 2-page paper or anything like that. It's worth 2 points. But we want to know, what is their background? This is getting in, kind of like what we talked about yesterday, not just focusing on our skills and what we're doing, but focusing on the psychosocial part, right? Bringing what are their stressors, basically? When they go home, what are they going home to? especially if they have a new diagnosis. How is that going to affect their home life, their family life, all of that? So telling us about that. 10 is the developmental stage. This is one of those pieces that, oh, she has in here. The section must include a reference, because who knows all the theorists by memory? Even if you do, it's still a source, right? So what developmental stage? I don't think I put the Erickson thing in here. I'm going to upload that in here. I've got a form that has, we usually use Erickson, developmental stages. You guys have heard of Eric Erickson. Is it Eric Erickson? Eric, my friend Eric, developmental stages. So the developmental stage is not necessarily always, do you always have them put what their ages are? Because I feel like sometimes, I'll put this up there, but it goes through all of the developmental stages. And to me, sometimes it really does depend on your patient, right? A lot of them are probably going to be in the adulthood or the maturity, which is 50 plus years, which is integrity versus despair. And then explaining why you think your patient is in that developmental stage, basically. I'll post this so you guys have an idea. You can also just Google Eric Erickson and then put your, I'm sure we have a book that has that in there. I'm sure their texts have it. Texts are like this thick. They probably have that. Oh, my baby. Thank you. Erickson's 8 stages of development. So you're going to pick a development stage and tell us why your patient is in that stage. Gotta put research in here. What else about that? And then include your reference. 11, almost done. We're getting there, over halfway. What are the possible barriers to communication, and how will you use your therapeutic communication to be effective? 3 points for this section. So don't forget to answer all the parts. So it doesn't necessarily just have to be, well, they're hard of hearing, right? There's other barriers. Maybe they have severe pain. That's a barrier. Maybe they have family members. Who knows that family members can be barriers, right? Barriers to communication because they won't let the patient talk, or for whatever reason. And how are you going to use therapeutic communication? Maybe you're going to not use medical jargon, or how are you going to use that therapeutic communication to be effective with your patient based on those barriers? So if they have family members that are maybe a big barrier, or they have a lot of pain, how are you going to get around that to effectively communicate with them? Education, here's the education one. Just remember I put that there is 2 parts to this. So what education was provided? We're always providing education. If you come to this point and you're like, I didn't, then we have a problem, okay? Make sure that you're coming, if once again, if your patient has a chest tube, maybe you want to educate them on that today, or proper ambulation with the chest tube, or, you know, whatever your patient is there for, make sure you're thinking about that ahead of time too. Coming with a plan. We talked a lot about teach back, right, or show back. What are we going to educate them on? And what was their response? Were they like, we have patients that are like, I don't want to know about that, right? And they're very like, I don't care. They were obviously not responsive, but then we have other family members and clients that are very responsive. So how did they respond to that? You look like you're going to say something. Okay. Remember 2 sections. Okay, then the lab parts. Number 1, you don't have to put medications. Whoop, whoop. Okay, on your data collection, you had to have all the medications, right? You do not have to put your medications on the clinical guide. They're all going to be on your concept map. Okay, so for labs, this is very nice. This is very nice, this section. Each lab needs to be listed separately. So for example, you're not going to put just CBC, right? Because CBC encompasses, you know, white blood cells, red blood cells, hemoglobin, all of that. You're going to put them individually, okay? And have their own little boxes. And so we've got this easy little template right here. You have 4 different things we're asking you up here in the black, 4 different things. So here they are, just literally jot them out. What's the significance of this? What would be the significance of doing post-delivery hemoglobin? Why are you doing that for your patient, okay? Symptoms to monitor, signs and symptoms to monitor. If they have a low hemoglobin, what signs and symptoms are they going to have? What are some potential complications that they could have because of this low hemoglobin? And then what are our nursing interventions? Okay, what are you going to maybe be watching for? Are you going to check vitals maybe more frequently because of this? Or what are you going to do? Okay, so there's 4 parts to that all out there. It's going to help you organize your thoughts a little bit better if you have these 4 sections kind of jotted out like this. Okay, questions about lab, there's a link on here, plus there's a bunch of lab books, plus you guys probably have a diagnostic test book with you. Skyscape. Make sure that you see up here, you've got some other examples. A lot of people would just think that it's just labs, okay? But it's also diagnostic tests. So if they have x-rays, MRIs, ultrasounds, cultures, if they're on telemetry, if they had an echo, there's a lot of other diagnostic tests. So I see that a lot. So keep that in mind. Don't just put labs, think about other diagnostic tests. Yes. So we don't like the word abnormal because they could have maybe a white count that's like 0.2 off, and it's going to be red in EPIC. So that's another thing that we can talk about in clinical. You're going to come to me and say, or not you in particular, but anybody come to me and say, I don't know what labs to put. What labs do you want me to put on this guide? And I'll say, what labs are pertinent to your patient today? For Melanie's patient, if they had a hemoglobin post-op day 1 or post day 1, that's important. That's pertinent, right? In different areas, they're in different patients, different labs are going to be pertinent. And you guys hate to hear that every year. I get it. But that's part of the critical thinking point. If you're looking at, normally when you're first looking at labs as a student, it's like, well, that's red, that's abnormal. But we all know that like 0.1 off of a hemoglobin of being normal is not abnormal. I mean, like the patient's fine, right? So I wouldn't want you to put that on there because that's not pertinent, right? So when we can do that, we'll get you used to that in clinical. I'll say, what's going on with your patient? Why would you want to put an INR? Or why would you want to put this white count or a SED rate or whatever on there, okay? Right, exactly. Oh, okay, sorry. Yep, sorry. Right, like if part of the CBC was off, just put that part of the CBC that was off. Yep. Sorry, that was like 10-minute explanation for something you didn't want to know. Yeah. Yeah, good point. Right. Yep. So they're on Coumadin. Pretty important to put their PTINR, right? What's the other one I was thinking of? If they're there, maybe they've been there for pneumonia or aspiration pneumonia or something, but their chest x-ray now is normal, that would still be, that's a pertinent diagnostic test, right? So that's kind of what we mean by that. And we'll get you guys used to that on clinical too. Any other questions about that? Yes. Well, some patients are there for like 3 months, so like Vibro patients. So no, we can go over that in clinical too. You might want to take, like, say they've had a daily hemoglobin for like 2 weeks, maybe take the first one that was really off and maybe the last couple ones or something like that. Yeah. Whoop. Okay. Last part. So now we're going over, thanks. And we're reflecting on our goals. I just love reflection. I do. I feel like it's venting. Just take it as venting. Well, not venting, but like venting about your what you got to do, okay? Make sure that you address each goal. Were you able to meet your goals? If you weren't, I don't just want to hear, I did not get to learn about chest tubes. Okay, well, why didn't you get to learn? I mean, that's kind of silly because you should be able to learn because you could do it right then and there. You can go home and learn about chest tubes, right? But say you didn't get to, the chest tube was removed, so you didn't get to do your psychomotor goal of actually, measuring the output. Okay, then you could say, my patient's chest tube was removed, and so I didn't get to check the output on their chest tube because it was removed. However, I did get to do this today because there's always something that gets added on that you're like, I wish I would have had this psychomotor goal, or do you know what I'm saying? So your goals and your reflection on your goals might change a little bit, but just don't put, I didn't meet my goals. Okay, just it's a little bit more of explanation about your day. Okay. Effective reflection. This is the love of not many students. It can be confusing because we want you so many times to be black and white about what's going on and what happened. This is not a reflection of your day. I found a lot of students come in and they just reflect on their day. I had a really great patient. I feel like I got along with them great. I don't want to hear about your day. Again, I know about your day, right? This is literally, say your patient had, they did not want to get out of bed because they viewed that their health was fine and they felt like walking was stupid. You feel differently about that, do you not? As a nursing student, you know you're going to have different feelings than what your patients feel, right? You can say, I had a really hard time because I felt like my patient did not want to get up and walk. And that was really difficult for me, but this is how I got over it. What's another good example? Pain sometimes, you know what? Some patients don't want pain meds. That's that's an effective reflection because you should feel differently about that as a nurse. You should, if they're like, I don't want to take pain meds. I felt and I believe that my patient should have had better pain control for this reason. Okay, so it's a lot. Think about feelings, think about attitudes, beliefs. Um, it can be I've had where you've had great patients and you agree with every single thing. They're a perfect patient. And then students will say, I don't know how to reflect on that. Well, literally reflect on that. Like I felt like my patient and they had a great attitude today. They believed in all the things that I was telling them to do. They listened to me. Um, what else about effective? That is also on that learning definitions in here, right there, the learning goal and cultural competency definition. The other part to this is that you then, so you talk about, you give a little effective reflection, and then after you complete your reflection, make sure that you write one effective goal that you could have used to care for them more effectively. Sometimes we get in those situations and it's like, I wish that I would have listened to my patient more and gotten them to get up more, or really had the time to just sit and reflect with them or communicate with them better, or yeah. So what's your goal? What could you have done differently? So two parts to that: reflection, and then what effective goal you could have used to care for them more effectively. Let's for 3 points for that. Comments about effective reflection? I feel like it's always the mushy area a little bit. Stacy, Jesse, anything? No? Okay. Nobody likes effective reflection. It's all silent in here. Okay, last piece. References and quality of paperwork. This is where you get 2 points. So I put in here, areas that need to follow APA guidelines include anywhere in this guide where you may have researched. So where are you going to do research? Maybe with your goals, maybe you are. Your labs, definitely, right? Make sure that you put that in this section, okay? Lab section, theorist section, you're going to be looking that up. What else? If you researched your interventions, right, then that source needs to be on that as well, okay? It does help, you guys probably have learned this from the Pioneer, but it does help to have a reference page on a separate document that you can then attach to, Jen's nodding, attach to every paperwork, okay? So this first week, when you go, fill out a separate reference page on a document or a document, and then just save it as your reference page. If you research something new, add it to your reference page, because then you don't have to do a new reference page every single week. Just save it on there. And then plus, if you get comments like, this needs to be changed because your APA is wrong here or there, you make those changes, you save it, good. Attach it to the next one. Okay. But you can take it out. But you can take them out and then take the ones out you didn't use. It'll save time. I know. I know. Okay. Right. What's that? Right. Yeah, you just have to submit one ref because you're submitting your guide, you're submitting your map, and then you're usually attaching, if you have a separate one, you're attaching your reference page as well. Yeah. But you can put all your references on that one reference page. You don't have to do a separate one for your map and your, right? Okay. Just make, I don't step on your toes. Okay. Let's take a 10-minute break. Walk around.